So welcome to the class. So this class is about bacterial sepsis following the pregnancy. It is a green top guideline number 64B published in April 2012. So last time we have discussed about the bacterial sepsis during the pregnancy. That was 64A guideline. Now this is the bacterial sepsis following the pregnancy. Okay. So this particular sepsis is a major cause of maternal death. So this particular guideline will provide the information about the management of sepsis in the puerperium, that is from birth up to 6 weeks postnatally. Okay, this focuses mainly on the genital tract infections, especially endometritis. It covers recognition, investigations, and management of febrile bacterial illness in the postpartum period, including the post-abortion sepsis. Last time only we have discussed about the mortality. If you are asked about the severe sepsis mortality, it is 20 to 40%. But if it is a septic shock, then the mortality is 60%. So when the question is asking, please read the question carefully, whether they are asking severe sepsis related mortality or a septic shock related mortality. Okay, then how to decide whether she is in septic shock or not, that we'll see subsequently. Okay, so these definitions also we have seen in the last lecture, and this I have sent you on the YouTube also. Okay, in the group. So sepsis is an infection and its systemic manifestation. Severe sepsis is a sepsis plus organ dysfunction or tissue hypoperfusion. And septic shock is a persistent hypoperfusion despite of giving fluids. Okay, so in spite of fluid resuscitation, if there is a persistent hypoperfusion, then we label this as a septic shock. Okay, so if there is only sepsis and organ dysfunction or tissue hypoperfusion, it will be severe sepsis. But in spite of fluid resuscitation, if the tissue hypoperfusion is persistent, we call it as a septic shock. Okay. Now let's see about the symptoms in the puerperium, which may be less typical than in non-pregnant women, and it requires high suspicion. Okay. The peculiarity is that disease progression may be very rapid in the postpartum period, and genital tract sepsis may present with a severe constant abdominal pain and tenderness, and this is not relieved by the analgesia. So that requires a special attention. So if you have a patient with a scenario where there is a constant abdominal pain, tenderness, and it is not relieved by the analgesia, think of postpartum sepsis. Okay. Now, who are at increased risk of sepsis? So there are multiple factors. Many women had more than one factor, and carrier or acquisition of invasive organisms such as group A streptococci is an additional risk factor. So these factors are divided into maternal factors, obstetric factors, and other risk factors. Maternal factors such as obesity, diabetes, impaired immunity, anemia, vaginal discharge, history of pelvic infection, etc. And obstetric, like there may be some procedure which has been performed, like amniocentesis or invasive procedure, cervical encirclement, or there is a history of PROM, vaginal trauma, cesarean section, wound hematoma, or RPOC, written products of conception, and other. There may be contact with a group A streptococcal infection in the contact or the family. And another is a black or minority ethnic origin. Last time we have discussed about the mortality and the ethnicity association. Okay. Coming to the common organisms, again SBA can be asked here. Common organisms causing sepsis in the puerperium. Major pathogens are group A streptococci. Okay, gas. That is the group A streptococci. That is Streptococcus pyogenes. Sometimes this you get confused because there is no gas is given, or group A streptococcus. The given is a Streptococcus pyogenes. Okay, so the answer could be group A streptococcus or this Streptococcus pyogenes also. And E. coli is next, then Staphylococcus aureus, Streptococcus pneumoniae, and other are less common but important, like MRSA, methicillin resistant Staphylococcus aureus, or Clostridium septicum, or Morganella morganum. So these are the total organism, but the most common will be group A streptococci or the Streptococcus pyogenes. This is a frequently asked SBA, so please concentrate on this. And all my videos, please, wherever I say, make a note of that particular, so that you'll be very ready during the examination. Then let's see about the gas and MRSA, etc. That is group A streptococcus was one of the leading cause and responsible for many deaths. Then MRSA rising incidence worldwide, and there were also some deaths which have been reported. This is due to the PBL producing MRSA after cesarean section. Okay. Then gram-negative ESBL producers. Okay, extended spectrum beta lactamase producers. Okay, like E. coli and all. They cause resistant UTIs such as co-amoxiclav and cephalosporin resistance is there. So gram-negative ESBL and Clostridium species, rare but ones Clostridium septicum. These are not important from the examination point of view. I'm just telling you from understanding point of view. But here what you remember is a group A Streptococcus in the periperium is one of the major pathogen for the sepsis. Now let's see about the clinical symptoms and signs or the risk factors suggestive of sepsis during pregnancy or postpartum. And these are the red flags or features in patients with suspected sepsis that indicate high risk of sepsis. Okay, so if you see these particular features, there is a high risk of sepsis and it requires immediate management with initiation of the sepsis bundle for inpatients or referral by blue light transfer from the community. So either they should be referred to from the community to the hospital, or if they are inpatient, you have to initiate the sepsis bundle. Okay, so what will be the next step if these features are present? Okay, first thing, it requires immediate management, okay, with initiation of the sepsis bundle, or there should be higher if referral by blue light transfer from the community. Okay, now what are these features? So if there is objective evidence of altered mental state, like a GCS score is less than 15, non-alert in AVPO classification, that is alertness, voice, etc., pain, etc. Then RR respiratory rate is more than 25 breaths per minute. Oxygen saturation less than 94. Heart rate is more than 130. Blood pressure systolic is less than 90. Urine output is not passed in more than 12 hours, or if catheterized less than 0.5 ml per kg urine per hour. Now, if these amber flags or features in patients with suspected sepsis that indicate moderate risk of sepsis. So these patients are at a risk, moderate risk of sepsis, and this warrants senior clinical review within 1 hour for patients or as soon as in the community. So this also you should know. So these patients should be seen by the senior within 1 hour. Okay, so if you get these particular features, think of moderate sepsis. These are red flags or the amber flags, and there has to be clinical review within 1 hour, or there should be transferred from the community to the referring hospital. Okay, then causes of sepsis outside the genital tract. You need to take into account the general history and clinical examination, consider admission if she is unwell, dehydrated, vomiting, etc. And likely causes may be mastitis, UTI, pneumonia, skin soft tissue infection, gastroenteritis, pharyngitis, etc. Okay, so these are the causes outside the genital tract. So it need not only be the genital tract infection. Okay, now let's see about these non-genital tract sources. Like there can be mastitis, which will present with a breast pain, abscess risk, toxic shock, necrotizing fasciitis. So these can be the complications. Urinary tract infection generally caused by the gram-negative organisms and can lead to pyelonephritis. Pneumonia, severe pneumonia may need ICU input. Okay, and it will require beta-lactam plus macrolide for typical or atypical coverage. If there is a hemoptysis, think of if there is a hemoptysis, then it is a pneumococcal pneumonia. This has also been asked. So if there is a hemoptysis, think of pneumococcal pneumonia. Okay, and if there is a severe hemoptysis with low WBC count, think of PVL producing staph necrotizing pneumonia. Mortality is more than 70%, and diagnosis is on sputum culture or urinary pneumococcal antigen. Okay, so if there is a hemoptysis with low WBC count, then it is a PVL producing staph necrotizing pneumonia. And if there is a hemoptysis, think of pneumococcal pneumonia. Okay. Then skin and soft tissue infection. Always check the cannula sites and wound, etc., etc. And what exactly you need to do? Remove infected devices immediately. Inspect the cannula site 2 times a day. And for this PVL producing staphylococci can lead to recurrent abscesses. Then gas seeding may mimic thrombosis. Necrotizing fasciitis, there is a very typical, it is a very severe pain, and later it will form the blisters, there will be necrosis, there can be shock and organ dysfunction, and this requires critical care. So when there is a necrotizing fasciitis, there will be buzzwords like a severe pain, and it is not relieved by the analgesics. Okay, so that will point out to the necrotizing fasciitis. Then regional anesthesia related, like block related meningitis, spinal abscess, well, headache, photophobia, etc. And wound infection, peripheral cannula thrombophlebitis, caesarean or episiotomy wounds, skin and soft tissue infection may present as a rash, conjunctival redness. So this conjunctival suffusion is very typical of toxic shock syndrome. Okay. Then necrotizing fasciitis, agonizing pain, early feature, and there may or may not be skin changes also, but later it will lead to blisters and necrosis. So if there is agonizing pain but no skin changes, still it is a necrotizing fasciitis, but later on it will lead to blisters and necrosis. So these are the typical features. You should look into the scenario what they have given. Okay. Now let's see about the amber flags or the moderate risk. This we have already discussed. Sometimes they ask you the question about respiratory rate. What respiratory rate will be there? So they have given this more than 20 here. Okay, 21 to 24 per minute. Okay. Then in the previous, which I have copied directly from the guideline, there they have given. Sorry, here they have mentioned more than or equal to 25 per minute. Okay, so at two places there is a two different figure, but I felt 20 is going to be more appropriate. But you can also go through the guideline. If you feel anything for the discussion, we can always have a discussion. Okay, so here they have mentioned about 21 to 24 per minute, and in the previous table they have mentioned more than or equal to 25. Okay, heart rate, this is definitely there. So this all requires clinical review within 1 hour. Okay, so recent procedures, there can be invasive procedure in the last 6 weeks, PROM, prolonged vaginal bleeding, abdominal pain, etc. in the post-birth cases. Okay. So common symptoms of sepsis in the puerperium, there will be fever, rigors, diarrhea and vomiting may indicate exotoxin production and early toxic shock syndrome. Okay. Then breast engorgement, redness, rash, generally maculopapular rash, abdominal or pelvic pain, tenderness, wound infection, spreading cellulitis, discharge, etc. Offensive vaginal discharge is suggestive of anaerobe serosanguinous, is suggestive of streptococcal infection. So look for what kind of vaginal discharge they have given. Okay, if it is anaerobe, it will be smelly, and serosanguinous if it is a streptococcal infection. There might be productive cough, urinary symptoms, etc. And AVPU score is alert, voice, pain and unresponsive. CVS coronary villus sampling, group A streptococcus, and eye gas, that is invasive group A streptococcus. These are the abbreviations which have been used. Now infectious disease history to note. Okay, always look for some risk factor in the history. Okay, if there is a recent illness or there is a close contact, think of streptococcal infection like sore throat, impetigo. Generally, it spreads through the close contact. Okay, if she is a case of IV drug misuse, think of staphylococcal or streptococcal sepsis leading to endocarditis, blood-borne viruses, etc. If there is a febrile illness with chills and rigors, suggest bacteremia. GI symptoms like diarrhea, vomiting, foodborne pathogens like Clostridium difficile or early toxic shock syndrome. Then resistant organisms like ESBL, extended spectrum beta lactamase producers, or VR, vancomycin resistant enterococci, or MRS, methicillin resistant Staphylococcus aureus. This will alter the empirical antibiotics and may require isolation. Okay. Then food exposures, unpasteurized milk, Salmonella, Campylobacter, Listeria. So this particular history also in the scenario is going to be very, very important to think of what organism you are dealing with. Okay. So animal or bird exposure, Campylobacter psittaci, or Q fever, Coxiella burnetii. This was also one of the questions which was asked long back. For the organism for producing Q fever is a Coxiella burnetii. Okay. So recent travel or if there is a overseas hospitalization, in that particular case, high risk of multi-drug resistant organisms, and this requires discussion with the microbiology. So these particular organisms and the typical buzzwords, please remember from this chart. Okay. So specific situations warranting admission. So which situations will warrant admission? If there is a sepsis, early sepsis, that is postpartum within 12 hours, likely to be gas infection. Okay, group A streptococcal. If there is a severe continuous pain, may suggest necrotizing fasciitis. Persistent vaginal bleeding plus abdominal pain, exclude infection. Abdominal pain plus fever, which is more than 38, and there is a tachycardia, always start a IV antibiotics. antibiotics. Okay, so community level, if you notice this, suspect maternal sepsis and advise referral, and screen for red flags. This all we have discussed all this. Okay, an urgent referral to the hospital, emergency ambulance if severely unwell. Okay, in specific situation. Okay, if it is within 12 hours postpartum, there is a severe pain, consider gas or necrotizing fasciitis. Persistent vaginal bleeding plus abdominal pain, rule out infection and refer immediately to maternity unit. On hospital admission, in this particular case, admit and start IV antibiotics and treatment. Do not wait for the investigation. Start high dose broad spectrum antibiotics immediately. Okay, but before this, there is a sepsis 6 bundle which we will be discussing. So okay, so that also you need to note. Okay, so triggers for the involvement of other specialties. So when to involve other specialties? All puerperal sepsis, discuss with the clinical microbiologist and infectious disease physician. Send appropriate specimens urgently. Start antimicrobials within 1 hour of recognition. So antibiotics should be started within 1 hour of recognition of the sepsis. Women with multi-resistant organisms like ESBL, MRSA, gas, or PVL producing staphylococci, no, you need to notify infection to the infection control team. Suspected necrotizing fasciitis involve always ICU care. Surgical opinion is required. Maybe plastic or reconstructive surgeon is important here. And seek early specialist input if unusual or rare infections are suspected. So look for this necrotizing fasciitis if there is a severe pain. This further will require ICU care and surgical opinion. Okay, so these are the typical things you look into the scenario after identification for the specific infection. Okay, now coming to the key investigations in suspected sepsis. Blood culture is essential. Before antibiotics, always take the sample for the blood culture. Do not delay the treatment. Start antibiotics immediately. Then serum lactate, it should be measured within 6 hours. And if it is more than 4 millimoles per liter, it indicates tissue hypoperfusion. Okay. And if it is 2 or more, then you have to repeat it. And that indicates the severe sepsis. Okay. But if it is 4 or more, it is a case of septic shock. So then you will also do the imaging studies. This is also asked. Sometimes we get confused whether to select 2 or 4 because both will be their option. So if you are dealing with septic shock, 4 or more, okay, it is equal to or more 4. That is the answer. Okay, imaging, chest X-ray, pelvic USG, CT, etc. You will do. Then routine blood like a full blood count, urea, electrolyte, CRP, swabs you will send, throat swab, urine swab, HVS, placental wound swab you will send. All these tests you will send. Then special test, MRSA screening, nasal swab if the status is unknown. Then stool test for Clostridium difficile toxin if diarrhea after the antibiotics. Okay, if you have got a diarrhea after the antibiotics, think of Clostridium difficile. Okay, this is also one of the recall question. Then culture for Salmonella, Campylobacter if there is a diarrhea. Okay, then alert lab for Listeria, parasites, typhoid, cholera if relevant history, cheese, cured meats, etc. So these particular questions you will find in your paper 1 especially. Okay. And then how about the interpretation of the test? If you get a gram-positive cocci in chains, it is a streptococcus. Mixed organism will be from gut flora or anaerobe. Then if you have a rising CRP and there is a thrombocytosis and swinging fever, think of some abscess or hematoma. Okay. Then first 6 hours sepsis management bundle. This is modified from SSC, that is surviving sepsis campaign. Okay, so this is first. These are the tasks which are to be performed in the first 6 hours after identification or after suspicion of the sepsis. Okay, that is called a sepsis management bundle. So first you will do this, send the culture, obtain the blood culture before antibiotics. Antibiotics will be given within 1 hour of the recognition. Then lactate, measure the serum lactate. If there is a hypotension, you will give fluid. If it is a more than 4 milliliter or 4 millimole per liter, give more than 20 ml per kg crystalloid. Okay, so this is the dose at which we should give the crystalloid. At one place they have mentioned about 30 ml also, but during pregnancy I think this is the most appropriate figure. But however, I will also go through once again this whether 20 or 30. According to me, the 20 should be the answer. Okay, you can also keep in mind to when you read about this particular guideline. So fluids, if there is hypotension or the lactate level more than 4 millimole, start with a fluid resuscitation. Crystalloid is of first choice and 20 ml per kg. Okay, vasopressor, if there is no response to fluid resuscitation, you will add a vasopressor. You will maintain mean arterial pressure more than 65, and if there is a septic shock, the persistent hypotension, lactate more than 4, then target CVP should be around 8 or more, and target SCVO2 will be more than 70% or SVO2 more than 65%. Okay, mixed venous oxygen saturation should be 65%. Okay, so this is the surviving sepsis campaign 1 hour bundle of care of elements. Okay, so last slide was about the task to be performed within 6 hours. Okay, and this slide is about surviving sepsis campaign 1 hour bundle. Okay, so from this only they have taken this. So sepsis management bundle, this is modified from the same sepsis survival campaign. Okay, this is surviving sepsis campaign 1 hour bundle. Okay, so measure blood lactate, obtain blood culture before antibiotics, but do not delay. Administer broad spectrum antibiotics. Begin rapid administration. So 1 hour bundle mentions 30 ml per kg crystalloid. Okay, and when you have a lactate more than 4, then apply vasopressor if patient is hypotension after fluid resuscitation, and maintain MAP of more than or equal to 65, and remeasure lactate within 1 hour if initial lactate is elevated. So if you get more than 2 millimole per liter, you have to repeat the lactate, okay, within 1 hour. Okay, you will send this as a blood investigation once again. Okay, now same thing is mentioned here. You will take the blood culture 2 sets before the antibiotic, HSV PCR whenever indicated, serum lactate you will send, and imaging. All these imaging also we have discussed. Then other microbiological samples will depending upon the clinical suspicion, and all these routine tests we are going to send, and any virological testing as per the indication, then throat swab, etc., and MRSA nasal swab. This also we have discussed. Okay. Now coming to the antibiotic. Now here also the questions are asked on this particular flow chart. Okay. Antibiotic, they are asking about the spectrum, which organism is identified and what will be the antibiotic of choice. So they may give you some specific infection and will ask you the antibiotic of choice. So we should know the spectrum of each antibiotic. Okay. Now let's talk about Coamox clav, what it cover and what it will not cover. It will cover the streptococci, methicillin sensitive streptococcus aureus, anaerobes, and many gram negatives will be covered. However, it will not be covering MRSA and Pseudomonas. Okay, and increased risk of necrotizing enterocolitis in utero exposure. So what is the side effect of Coamox clav for the fetus? It increases the risk of neonatal enterocolitis, necrotizing enterocolitis. This also you should remember from SBA point of view. And this Coamox clav is not covering MRSA and Pseudomonas. Okay, immediately after Coamox clav, just go to the piperacillin and tazobactam. This also has got a similar to Coamox clav, but it will act against Pseudomonas. Okay, here MRSA and Pseudomonas were not, but piperacillin and tazobactam. So remember P for P. So this will cover, this will be similar to Coamox clav, but it will cover Pseudomonas, but it will not cover MRSA, and it is poor against ESBL coliforms and poor CSF penetration. Okay, but it advantage, it is a renal sparing and avoiding beta lactamase allergy. Okay, so those patients who are allergic to penicillin, you cannot give piperacillin tazobactam. So Coamox clav and this piptas, same spectrum except Pseudomonas. Is it clear? Clear this much?
Yes, sir.
Okay. Then these two study together, metronidazole and clindamycin. Both actually cover anaerobes, both. But when you talk about metronidazole, it will cover exclusively anaerobe, no gram positive, negative. It is not recovered along with clinda or piptas. Okay, because they are also covering the some anaerobes. Okay, used with cefotaxime for chorioamnitis prophylaxis. Okay, now coming to the clinda. What clinda will cover? Gas, GBS, group B and group A streptococci. Okay, but mainly group A. Okay, staphylococci. Some MRSA it will cover, and it will also cover anaerobes also. Okay, so metronidazole and clinda, what is the difference? This will cover anaerobes. This will also cover anaerobe, but along with that, it will cover mainly gram-positive ones and some MRSA. Okay, but it is no longer recommended for GBS prophylaxis. Okay, because there is increased clostridial difficult risk. Okay, so Clinda don't select when you are talking about GBS. Okay, then how does it have toxin suppression and non-nephrotoxic? These are the two important features about the clindamycin. Then talking about the cephalosporin, it will cover both. It will cover mainly gram-positive gas plus GBS and streptococci. It will not cover these negatives, gram negatives. It will also not cover MRSA, and it is contraindicated in severe beta-lactam allergy, and it also increases the Clostridium difficile risk. Okay, coming to the carbapenems. Carbapenems are the broadest spectrum. Here you will get everything will be covered, like a gram positive, gram negative, anaerobe. Everything will be, but what will not be covered? Again, MRSA is not covered. So when the question is about MRSA, think of vancomycin. Okay, if your question is about MRSA coverage, think of vancomycin. When you are talking about gram positive, gram negative plus anaerobe, think of this carbapenems. Okay, and it has got a good CSF penetration. It is not for severe beta-lactam allergies, less than 1% cross reaction in moderate allergy. Okay, gentamicin, we know well that it is mainly against the gram negative, and it also covers Pseudomonas also. No streptococci or no anaerobes. Inactivated in pus and anaerobes. Nephrotoxic, ototoxic, usually start dosing sepsis is given. Okay, vancomycin, MRSA, option in severe penicillin allergy. So in GBS prophylaxis, if you are asked about the drug of choice, when there is a penicillin allergy, think of vancomycin. Otherwise, penicillin is the drug of choice. I'll be posting this particular GBS video in the group soon. Okay, IV, it is to be given IV only, and except in Clostridium difficile, monitor serum level. Risk of red man syndrome is there. Okay, with vancomycin. Then all these listed agents are safe in breastfeeding. Quinolones, tetracycline, linezolid not used in the puerperium for the safety concerns. Okay. What is the role of IV immunoglobulin in puerperial sepsis? There are hardly 2-3 things you should remember about IVIG. Severe gram-positive necrotizing infection and TSS, that is toxic shock syndrome, which are not responding to other measures, you go for IVIG. Okay. So if the scenario says that this particular toxic shock syndrome, this broad spectrum antibiotic has been used but not effective, then IVIG can be the option. Setting will be critically ill women under critical care. Administration with a blood warming device, and contraindication will be congenital IgA deficiency, and it neutralizes exotoxin and super antigens, improves outcome in severe cases. Okay. So this is the congenital IgA deficiency is a contraindication for IVIG. It is indicated in severe infection where other antibiotics have failed. Now coming to the when should the fetus be monitored? How should the fetus be monitored, and timing and mode of the birth? It is decided by the obstetrician. Okay. If preterm birth anticipated, consider what you will give: Maxelf for neuroprotection and antenatal corticosteroids. Then intrapartum, use continuous electronic fetal heart rate monitoring. Be cautious with the fetal blood sampling, and senior anesthetist to assess anesthesia type and need for invasive. So here, 2 things you should remember, 2 or 3 things, like if it is a preterm delivery, magnesium sulfate, antenatal corticosteroids. Even if there is a sepsis, then also it is indicated. Okay, for this fetal maturity. And intrapartum, continuous electronic fetal heart rate. So sometimes we think about the sepsis, so should we give steroids? But it is indicated, guidelines says steroids are indicated. Okay. Now what about the neonatal issues? Okay, what we need to address? So babies of women treated with sepsis during labor or within 24 hours before or after birth require assessment for risk factors and clinical indicators of neonatal infection. If either mother or baby has IGAS, that is invasive group A streptococcal infection postpartum, both should be treated with antibiotics. So if there is a IGAS, neonates require antibiotic treatment. If there is a sepsis, then neonate should be assessed for the risk factors and clinical indicators for neonatal infection. Okay, so this is what about the neonate. Now, what postnatal care and infection control issues should be considered? Here again, we should know few things, because sometimes there can be question. inform all pregnant and postnatal women about signs and symptoms. So red flag symptoms we need to teach to these patients about the genital tract infection. Aggressive treatment of gas in pregnancy, adopt full infection control precautions, including barrier nursing, and household contacts. If any of the contact has got a group A streptococcal infection, want to seek medical attention, and antibiotic prophylaxis will be started. Okay, so if household contact has got group A streptococcal infection, antibiotic prophylaxis is indicated. Now, suppose what about the healthcare? Suppose the healthcare worker is exposed to respiratory secretions of group A streptococcal case, then the healthcare worker will also require antibiotic prophylaxis. Okay, so here if there is only contact, that may indicate the antibiotic prophylaxis for the lady, and if there is exposure to the respiratory secretions by the healthcare worker, then the healthcare worker will also require a antibiotic prophylaxis. So that finishes the bacterial sepsis following the pregnancy in the period. Thank you.